Hello, my name's Faye and I'm an advanced clinical practitioner in the emergency department with a background in nursing. Welcome to your session today on fluid and electrolytes. Our learning points for today are to discuss what fluid balance is and why it is important. Look at the electrolytes in our body and what their role in the maintenance of fluid balance is. To discuss homeostasis and how it is maintained. Look at the different types of intravenous fluids with different properties and indications for use, and we will explore all of these and the pros and cons for each. We will then look at ways in which we can assess a patient's fluid status and consolidate what we have learnt by looking through some case scenarios. Fluid balance is the balance of input and output to allow metabolic processes to function correctly. In essence, the amount in and out need to be equal. The amount of fluid within our bodies differs with age. As you can see, as newborns we're about 75% water, as adult males we're 60% water, and as adult females 50% water. With age, the amount of water in our body decreases. Water is very important to our survival. The human body can survive for weeks without food, but it can only survive for days without water. These diagrams demonstrate the fluid ratio changes that occur as we age. The changes that occur with age are down to the ageing body affecting our kidneys, thirst trigger, heart function and hormone production, affecting the output and input of fluids. So what is the point of us having fluid in our body? As we have said, fluid is essential for life. It has many important roles to ensure we function and stay well. Fluid is used for the transportation of substances around our body. These substances include glucose, oxygen, carbon dioxide, electrolytes, antibodies, hormones, minerals and amino acids. Essentially, our blood vessels are the road and the fluid in our body is the car carrying substances to where they need to be. Thermoregulation is how our bodies maintain a certain temperature. In order for this to work, signals sent through our endocrine system are needed to encourage us to sweat when we are hot and to create vasodilation at the peripheries and to increase respiration. Excreting toxins mostly occurs through our kidneys. The kidneys filter out the substances needed back into our bodies and excretes the ones we don't need in our urine. We need water to transport chemicals around our body to allow metabolism in order for us to repair our cells, break down food into energy and fuel, and to eliminate waste products of this metabolism. This helps to maintain cell health, ensuring good hydration and correct fluid balance allows levels of chemicals to be optimal for this metabolism. Good hydration can stimulate the production of synovial fluid and reduce inflammation in our joints. The fluid acts as a buffer and a shock absorber, therefore keeping hydrated can reduce joint pain. Homeostasis is a buzzword for fluid balance and encompasses all of the above. Homeostasis is the maintenance of a constant, steady environment through ensuring a constant balance. Homeostasis controls our temperature to ensure optimal temperatures for enzymes to work. It controls our blood sugar levels for cell respiration in both aerobic and anaerobic processes, and it maintains the correct ratios of water within our body. As we can see from the last slide, fluid balance is very important. We have three main fluid compartments, and a balance amongst all three of these compartments is needed. 2/3 of our total fluid is within the extracellular compartments, and this is divided into plasma and interstitial fluid. 1/3 of our total fluid is intracellular. Extra fluid, as you can see in the picture to the right, is interstitial fluid. This is the fluid that bathes and surrounds our cells. A patient who has peripheral edema has too much fluid in their interstitial compartment. The second extracellular compartment is the plasma, or the intravascular compartment. Essentially, it's the fluid that flows through our vessels. The intracellular compartment is the fluid within our cells themselves, and this is where chemical reactions and metabolism occur. We need an equilibrium between these compartments, and this is achieved through a combination of two different pressures. In order to understand fluid balance, we need to understand fluid movement. Osmosis is the movement of water from an area where water concentration is high to an area where it is low to establish an equilibrium. When the concentration of a molecule is high, we have high osmosis or osmolarity, and as fluid will move to try and equalise this. Diffusion is the movement of molecules to establish an equilibrium. Molecules will diffuse across a semi-permeable membrane to create this equilibrium. Hydrostatic pressure is the pressure exerted onto a fluid and in our bodies. This pressure usually comes from the effect of the pumping heart and/or gravity. As our hearts pump, the pressure inside our blood vessels can be increased, and this forces fluid out into our interstitial spaces. Oncotic pressure is created by the pressure exerted from protein molecules. Large protein molecules help to keep fluid inside our blood vessels by essentially drawing fluid towards them. When large molecules are low or altered, fluid can leak out. If you think about a patient who has severe liver failure, albumin is produced by our livers, and therefore when our liver fails, albumin production can fall. Patients with severe liver failure can often develop ascites and peripheral edema because the albumin is a large protein molecule that helps to keep fluid within the intravascular compartments. When albumin levels drop, the fluid leaks into the interstitial compartments. A good way to think about hydrostatic and oncotic pressures is to think of a hydrostatic pressure as our pushing pressure and oncotic pressures as our pulling pressures. Here in the top left-hand picture, you can see a demonstration of osmosis. The fluid shifts to ensure an equal concentration, but the molecules do not change. The middle right picture demonstrates diffusion. You can see the molecules in the right-hand cup have been equally distributed throughout the fluid compared to the left, but the amount of fluid and the molecules has stayed the same. The picture to the bottom left shows hydrostatic and oncotic pressure. Hydrostatic pressure is pushing fluid out, whilst oncotic pressure is drawing fluids in. When the body is functioning well, this balance is maintained. However, there are many pathologies that can tip this balance, resulting in an unbalanced fluid compartment. These include, but are not limited to, liver failure, renal failure, heart failure, sepsis, hormone imbalances, such as those involving the pituitary gland, and malnutrition. Electrolytes also play an important part within fluid balance. The common electrolytes are sodium, potassium, calcium, magnesium, chloride, and also phosphate and bicarbonate. Electrolytes become ions when they are dissolved in water, and they carry an electric charge. Water is needed to transport electrolytes and also to keep them at correct concentrations to ensure nerve conduction and muscle contraction happens as and when it should. Remember, electrolytes, osmosis, diffusion, hydrostatic and oncotic pressures as we move on through the presentation. So how does our body control fluid homeostasis? We have 3 organs in our body that ensure this is maintained. We have the kidneys, brain and adrenal glands, and these are the leaders for fluid balance, and all of these rely very heavily on sodium levels to inform them of what changes are needed to optimise fluid balance. Our brains are amazing organs. In relation to fluid balance, receptors in our hypothalamus detect changes in sodium concentration. Let's think about fluid deficit. When our fluid volume decreases, the concentration of sodium in our blood will also decrease. Think back to osmosis. We have high osmosis or high osmolarity due to a high concentration of a molecule, in this case sodium. The rise in osmolarity is detected by osmoreceptors in our hypothalamus, and this has an effect on another gland within our brain, the pituitary gland. This effect causes the pituitary gland to release antidiuretic hormone, or as it's sometimes known, vasopressin. Vasopressin signals our kidneys to retain water. Through the retention of water, the water concentration increases and the sodium concentration and osmolarity decreases, and therefore the fluid deficit is corrected. Antidiuretic hormone is also influenced in the reverse when sensors of the atria of the heart detect stretch, and this indicates an overload of fluid causing the heart to stretch. When this occurs, the production of antidiuretic hormone is stopped, and this encourages the excretion of water, because there is no longer a hormone being released that encourages us to not release water. kidneys and the adrenal glands. These sound much more complicated, but there's just really a few more steps involved. Let's think it through. If we have a drop in our blood pressure, it is picked up by special kidney cells that cause the conversion of prorenin into renin, and this is the first part of our flow diagram. This renin is then converted into angiotensin, and then into angiotensin 1, and this is subsequently converted into angiotensin 2 by angioconverting enzyme. Let's think here about ACE inhibitors that we use, such as ramipril, in the management of hypertension. Angiotensin 2 effectively causes vasoconstriction. With antihypertensives, if we block this enzyme, then we reduce blood pressure. In the case of a drop in our blood pressure, this causes the release of angiotensin 2, which causes vasoconstriction, to increase our blood pressure. The vasoactive effect causes the blood pressure to increase, and it also causes the release of aldosterone from the renal cortex. Aldosterone then causes sodium to be reabsorbed at our kidneys, and this subsequently causes the reabsorption of water, also aiding in improving our blood pressures. The reaction also occurs when sodium levels are low in our blood, and the kidneys detect this through the reduction of filtered sodium through our kidneys, causing the release of aldosterone to encourage sodium to be reabsorbed at the kidneys. So let's have a look at the types of fluids that we can use. In terms of fluids, we can influence how fluid balance in our bodies is maintained. Fluids come with different molecules, and this relates to osmosis and diffusion, and also different tonicities relating to hydrostatic and oncotic pressures. In relation to the molecules, we have crystalloids, which are fluids with small molecules, and we also have colloids, which are fluids with much larger molecules. Tonicity relates to the concentration of a fluid. There exists isotonic, hypertonic, and hypotonic solutions. Let's now explore these a little bit further. Crystalloids. Crystalloids are what we are all familiar and comfortable with. These include plasmolite and normal saline. They contain small molecules which can move easily across semi-permeable membranes, such as those between the compartments, and they are used to increase volume in fluid deficit or for things such as fluid maintenance in patients that are nil by mouth. They are of low cost, and there's a very low risk of allergic reaction from crystalloids. Colloids, on the other hand, are large molecule fluids. Colloids are rarely used now, as much research has shown that there is no improvement in patient outcome when they're used for fluid replacement. Colloids are fluid with big molecules and therefore maintain a high osmotic pressure. The word colloids comes from the Greek word meaning glue, so if you think thick consistency, something that is similar to milk when you think of colloids. Colloids stay in the intravascular system longer due to these large molecules, but this can also result in renal failure due to the large molecular size and the synthetic nature of some colloids. They can also cause heart failure from excess fluid. There is a higher risk of reaction from colloids, such as anaphylaxis. Also, synthetic colloids can be made using gelatin. Therefore, we need to be aware of patients that may have preferences such as vegetarianism or vegans, and also those with religious beliefs. Those most commonly used colloids now are human albumin and FFP, and these are generally restricted to the use for very complex renal or liver failure patients. Isotonic solutions. Tonicity is the measured effect of the osmotic pressure. So effectively, an isotonic solution has the same tonicity or osmotic pull as our bodies. They are most commonly used for fluid resuscitation and maintenance. Examples of isotonic solutions are sodium chloride, plasmolite, and 5% dextrose. Hypotonic solutions have a much lower concentration, therefore they have a low osmotic pull. This results in shifting of fluid into the intracellular spaces to equalise concentrations. This can be used for rehydration and maintenance, but must be used with caution, particularly in the elderly, children, and patients with head injury, as they are at higher risk of developing cerebral edema. An example of a hypotonic solution is 5% dextrose, and this is when the dextrose has been used up in our body. Hypertonic solutions, as you can guess, are the opposite of hypotonic solutions, and they have a high molecule concentration which results in increased osmotic pressure, resulting in the pulling of fluids from our cells. These solutions are used to correct hyponatremia in some circumstances and to reduce edema, mostly cerebral edema. There are different types of hypertonic solutions that you can get. Hypertonic saline, both 3% and 1.9%, are mostly used in the correction of cerebral edema or severe hyponatremia. 10% dextrose is a hypertonic solution. Once the dextrose is used up in the body, the solution becomes water and is therefore a hypotonic solution. 5% dextrose and 0.45% saline is a hypertonic solution, but again, once the dextrose has been used up by the body, it becomes a hypotonic solution, and is therefore the sodium concentration is lower than that in our body. Whereas 5% dextrose in 0.9% saline becomes an isotonic solution once the dextrose has been used up. So let's have a look at the effects of isotonic solutions, hypotonic solutions, and hypertonic solutions. All of these eggs give you a visual idea. They've all been placed into the fluids of different tonicity. Our first egg on the left is plump and full, and that is because it's been sitting in a hypotonic solution where fluid was pulled into the egg to equalise the concentrations. The second egg has been sitting in an isotonic solution, therefore its shape and fluid content hasn't changed. Whereas the third egg was placed into a hypertonic solution where fluid was pulled out of the egg, drying it up. We've now had a look at the different types of fluid, so what we need to do next is look at how we assess our patients to work out whether they're in a fluid deficit or fluid excess. When we're doing our assessment of patients, things we can look for that indicate our patient is fluid depleted are tachycardia. Checking for radial pulses or brachial pulses can tell you a lot about the fluid status of a patient. A weak thready pulse lets you know that they're probably in a fluid deficit. If they're tachycardic, this means that the heart is working harder to try and pump more fluid around our body. Hypotension, or patients with a postural hypotensive drop when they stand, can also be depleted of fluids. Oliguria or anuria, relating to the production of no urine or a very reduced urine, indicates that there is not much fluid being filtered through the kidneys and therefore could indicate a fluid deficit. Reduced pedal pulses is very similar to as we were talking about the tachycardia. If you have weak thready pedal pulses or absent pedal pulses with cold feet, then you've probably got a hypovolemic patient. You can also assess skin turgor by just lifting the flap of the skin on the back of the hand, and if the skin bounces back to its pre-lifting position, the patient is well hydrated, but a reduction in this can indicate dehydration. Use this cautiously in the elderly as they tend to have a reduced skin turgor anyway. Looking at tongue turgor is also a more accurate diagnosis for fluid deficit. If there's a lot of ridges around the edges of the tongue, it can indicate somebody is dehydrated. Dry mucous membranes such as those of inside the mouth and the lips. A patient who is drowsy or confused. In the infant, a patient with a sunken fontanelle can indicate that they need some more fluids. Any patient who has a slow capillary refill time, and this is talking about central capillary refill time, where you press in the centre of the chest for 5 seconds and count how long it takes for the skin to be reperfused. In severe cases of fluid deficit, usually related to incorrect levels of sodium, can result in patients developing from seizures. Causes of fluid deficit include vomiting, diarrhoea, excessive sweating, poor oral intake, hemorrhage, infection, patients with dementia who may not want to eat, lose their reflex to eat or drink, or may just forget, or medically induced, so this is our patients who might be on diuretics and lose too much fluid that way. So fluid assessment in fluid excess patients. As with fluid deficit, these patients can also be tachycardic because the heart is trying to cope with the excess amount of fluid. These patients will have a raised jugular venous pressure, and if they're elevated with their head at 45 degrees and you turn their neck to the left and you can see the jugular vein within the neck, it can indicate that there's raised pressure there. Look for signs of edema. This can be lower limb edema, or it can be as extensive as up into the sacral area as well. When you push onto the skin, you get an indentation where the fluid has shifted outside of the interstitial fluids. You can get bubbly chest sounds from increased fluid within the lung tissues. You can also have added heart sounds from where the fluid is swooshing through the heart. Patients with liver failure can develop ascites, and this is a large abdomen full of fluid. And also if patients are having daily weights, particularly those with heart failure, an increased weight can indicate that their fluid is increased. Causes of this include liver failure, heart failure, kidney failure, and ion imbalances. We've now talked through causes of fluid deficit and fluid excess. We've had a look at the different types of fluid and how our bodies maintain our fluid balance. Moving on to the next part, we'll look at some case studies and talk them through. Case study 1 is a 34-year-old male called Bruno, and he was admitted to the hospital with abdominal pain and was diagnosed with appendicitis. You've just gone and done an observation round for him, and you found that he is only responding to voice. He's got a respiratory rate of 32 with a heart rate of 126. His blood pressure is 87/52, and he's got a raised temperature of 39.4. His saturations on room air are 92%. He feels peripherally cool with a central capillary refill time of 3 seconds. Thinking about whether Bruno is in fluid excess or deficit, I think we can quite safely say that he's in a fluid deficit. Bruno is tachycardic with a low blood pressure, and the cause of his fluid deficit is likely to be sepsis. In order to treat Bruno, we need to think about our sepsis 6. So this includes taking blood cultures, taking a VBG to look at his lactate level, trying to get him quick IV antibiotics, monitoring his fluid balance, starting oxygen if it's indicated, and in his case it would be, and also to start intravenous fluids. We initially start intravenous fluids at a bolus rate of 30 ml per kilogram. So in your average 60 kilogram adult, that would be about 1.8 litre fluid bolus. With Bruno, when we think about whether we would want to use a crystalloid or a colloid, we would want to use a crystalloid for Bruno. Our next patient is Mary, who's 85 years old, and she has been admitted with worsening shortness of breath, particularly when she lies down. When you go to assess her, you notice that she's more short of breath and she's working very hard to breathe. She's fully alert and has a respiratory rate of 37, and you can hear that her chest sounds quite bubbly. She has a heart rate of 107, a blood pressure of 198/101, and a temperature of 35.7. Her oxygen saturations on 15 litres via a non-rebreathe mask are 93%, and she feels cold and clammy to touch, with a capillary refill time of 5 seconds. Thinking about Mary and whether or not she's in an excess or a deficit, we can explain that she is in a fluid excess. She's likely in acute decompensated heart failure, and so in Mary's case, we would not want to give any fluids at all. We would want to give Mary a diuretic to get rid of some of that excess fluid that she has, and the most commonly used medication for that would be furosemide. Mary will also need to be on a fluid balance chart, and she will need to be carefully monitored. And it's worth highlighting that with Mary, she was cold and clammy, which some people can relate to people being in a fluid deficit. But when your heart is struggling to work because of too much fluid, you can also be cold and clammy. Thinking about children now, we have 1-year-old Maggie, who has had a 2-day history of diarrhoea. On assessing Maggie, you find she's alert with a respiratory rate of 43 and a heart rate of 190. She has a systolic blood pressure of 60 and a temperature of 37.4. Her oxygen saturation is 94% on room air. Her central capillary refill time is 4 seconds, and her parents report that she's not had a wet nappy for 12 hours. With Maggie, we can understand that she is definitely in a fluid deficit. She's had diarrhoea for 2 days, and this could contribute to her fluid deficit. She needs to have IV fluids, and in paediatrics we would generally give 10 to 20 milligrams per kilogram as a starting point and then reassess. In the case of Maggie, again, we would want to use a crystalloid, not a colloid. In summary of today's learning, we've looked at fluid balance and we look at how our bodies maintain that. We've had a look at the different types of electrolytes involved, and we've had a look at the different types of pressures involved in maintaining fluid balance, including hydrostatic, oncotic, we've looked at diffusion, and we've looked at osmosis. We've also discussed the different types of fluid and what the pros and cons of each of those are. And we've looked through how we can assess our patients and their fluid status so that we can then titrate our management according to that. Thank you very much for listening to my presentation today. If you have any questions or anything that you would like to ask me, you can find me down in the emergency department at East Surrey Hospital, or you can contact me on my email at faye.jardine@nhs.net. Thank you very much.